thank you very much for having me this morning. It's a pleasure to be here and to kick off the talks. To make sure the microphone can pick me up. I'm a clinical academic neurosurgeon. I'm based at the Royal Adelaide Hospital and now Adelaide University. A lot of my research endeavours have been supported by the NRF over the years. This is no exception. In fact, this is probably one of the largest supports we've had from NRF, this very special project. A lot of my clinical work is dealing in glioblastomas, and it's challenging work. The surgery can be quite challenging, but the frustrations are really the long-term management and the lack of any significant clinical progression. This is a project that is really the brainchild of Professor Michael Brown, who's here today, who's a very precious, very clever oncologist who has taken us, the neurosurgeons, on board to be part of this project. So I'm going to give you a neurosurgical spiel about CAR-T cell therapy and what role it's going to potentially have in advancing and having potentially a paradigm shift in neurosurgical treatment of glioblastoma. Why glioblastoma? Well, why not? It's a very aggressive brain tumour. It's common, very common. Median survival is not particularly good and hasn't improved all that much despite advances in chemotherapy and radiation therapy regimes. Survival is quite limited. A very small percentage of people survive beyond 2 or 3 years, particularly not beyond 5 years. And we can certainly do better. A lot of other medical treatments have improved amongst the years, but certainly not glioblastoma treatment. So what we do as neurosurgeons is we take away as much of the tumour as we possibly can, which can be challenging sometimes because of how precious the brain can be. And certain areas we just cannot touch without causing significant deficit, but we do try and remove as much of the tumour as we possibly can. And we follow that with radiation therapy and chemotherapy, which is a standardised regimen. And then it's typically a 6-month course of weekly chemotherapy tablets rather than injections these days. But despite that, these tumours almost always recur, with very few exceptions. So I'm going to touch briefly on CAR-T cell therapy because this is not my background. Unfortunately, Nicole after me is talking more about CAR-T cell therapy and how they developed. But CAR is the chimeric antigen reception, and T cells are the body's soldiers in fighting infection and disease processes. So we can collect specialised T cells in the body. In the lab, we can engineer them to fight certain things, including tumours. We can grow and expand the T cells in the laboratory, then we can put them back into the patient. In theory, that should attack tumours, perhaps better than chemotherapy and radiation therapy can. The target that we've elected to modify the T cells is the GD2 receptor, which is very common on glioblastomas. It's been found to be present on a large number of glioblastoma cells. And the good thing is that it's not present on normal brain cells. So if we tell the T cells to target the GD2 receptor, then in theory, in the brain, it should target the cancer cells and not the normal cells. One problem is getting the T cells to where it needs to be. Fortunately, the T cells can cross the specialised barrier, which is known as the blood-brain barrier, that normally protects the brain from outside influences. The other thing that we're exploring, and I'll talk more about this in a moment, is directly inserting the T cells right into the brain systems, the brain fluid spaces, and this is where the neurosurgeons come in. So our study design is a small study, so phase 1 study, which is mostly a safety study to prove that it's going to be safe rather than efficacious. We screen patients for the GD2 receptor. If they've got a certain amount, a certain percentage of GD2 on their tumour cells, then they're going to be eligible for this trial. And we can do this at the time of initial diagnosis. We then take some of the blood from the patients. We manufacture these CAR-T cells in the lab, and again, hopefully Nicole will tell you more about this. And then they can be stored, they can be frozen. We want to use them when the tumour comes back, and this is what we're exploring in patients when the tumour comes back after we've had all these standard surgery and chemotherapy agents, is to insert a very special device called a reservoir, which I'll explain in a moment. And then we can directly inject these CAR-T cells in a fluid right into the brain spaces and get it where it needs to be. So an EMEA reservoir is this thing. It looks like a little plastic dome, and it's attached to a catheter with little holes in the bottom of it. You can see there. Those holes sit within the ventricular space. It's a simple procedure. It's done with the patient asleep. A small incision is made on the scalp around about this region just here, and a little hole in the skull, and then the long part of the catheter sits inside the ventricle. You can see here that's the green arrow pointing down into the ventricular system, which is the brain's fluid spaces. And the dome part sits just outside of the skull. We can close the skin around that then. And what that gives us is a lovely little access point to put medications and drugs into the brain's fluid, and also withdraw brain fluid if we want to. So to put the CAR-T cells into the brain, once the wound is healed and the patient's recovered, at the overnight state typically, you sterilise the skin. You can draw up the CAR-T cells into a syringe, and you can inject it straight through the skin, through the little plastic dome, and it goes straight into the ventricular system, exactly where it needs to be. Patients monitored for a short period of time just to make sure that they're safe and make sure that the adverse effects, and they can go home. The standard journey for the patient now is, once the diagnosis of GBM has been made, we can screen the patients for eligibility of the GD2 receptor. We can accrue the CAR-T cells, we can put it in the laboratory, we can freeze it for later use, monitor the patient, and if the tumour comes back, then we've got this option of using CAR-T cells in the blood or directly in the brain fluid, and see if we can use these T cells to fight the cancer. There's been a lot of thought into this project, particularly about what happens if it goes wrong. And fortunately, we've got this something called a suicide switch. So if any patient has any adverse effects to it, we can give a medication and that kills the T cells that have been infused. If patients do well and there's no adverse effects, then we're in a stepwise escalation and more or less prove that this is safe to be used. And once we know it's safe, then we can expand it onto phase 2 and phase 3 clinical trials and really show that we can make a difference. So this is a busy slide, I won't go into too much detail. Finally, I just want to finish by saying that what the NRF is doing and the support of everyone in the audience is fantastic. These are very expensive trials to run, as you can imagine. Just the manufacturing the CAR-T cells alone, very expensive laboratory. You can imagine the quality control that needs to be taken in place for these. And then let alone just the theatre, just a single day case procedure to insert those in reservoirs runs to tens of thousands of dollars. So very expensive trials, but very exciting trials, and we're very grateful for the support from everyone in the room and the NRF to make these sorts of trials happen. So thank you for listening, and I'm happy to take any questions.
Thanks, Adam. So are there any questions?
Sure.
Yes?
Good morning, and thank you for everything that you are doing. I was just wondering, is the trials only open to people who have got primary brain tumours, or is there an arm that it will be extended for medicine?
Yep. That's a great question. So at the moment, this trial particularly is for primary brain tumours, and specifically glioblastomas, and specifically glioblastomas which have at least that GD2 cell population, so a very, very specialised subset population. The CAR-T cells have been used in other cancer types, particularly white cells and leukemias, and other more solid organ cancer types like melanomas and things of that nature. So I think it's very realistic that this sort of therapy can be used for non-primary brain tumours, but this project in particular is for primary brain tumours.
How do a patient get onto the trial?
Yeah.
Because we've had a reoccurrence.
Yeah. So again, excellent question. At the moment, we screen, and we are actively recruiting patients from now. So we're looking for patients who are having their primary tumour resected from now, and then they are screened and then monitored for future recurrence. So for patients at the moment who've already had their surgery, their STUC protocol, they aren't eligible for this trial in particular, but potentially phase 2, phase 3 trials, those sorts of patients might be able to be eligible for future trials.
So you don't have to have the tumour itself then to perform this TB plasma? You don't have to have the actual tumour?
Oh, so no, so we can do that retrospectively. So if the
Yeah.
tumour's been resected once
Yeah.
already, then
Yeah.
usually it is kept in the laboratory for future analysis,
Yeah.
and then we can test for the presence of that GD2 receptor.
Yeah.
Yeah.
Thank you.
Pleasure.
All right, I think in the interest of time, we've got a number of talks to get through, but thank you, Adam, again for a great talk, and I know you'll be around for a little bit afterwards.